अस्सलाम वालेकुम। आई होप के आप लोग खैरियत से होंगे। और सुबह का सेशन ज़रा आई नो कि ये 7 बजे से चल रहा है प्रोग्राम। और वी वेलकम सोसाइटी सर, आप लोगों को वेलकम करते हैं कराची में। और बड़ा अपने मेला सजा रहे हैं और आइंदा 2 दिन में इंशाल्लाह सजाएंगे। तो पहली कॉल तो यही है कि भाई जाग जाएं, थोड़ी देर तो जागना पड़ेगा। अब यहाँ कॉफ़ी वॉफ़ी का कुछ लोगों को कॉफ़ी की ज़रूरत होती है जागने के लिए, लेकिन शायद कॉफ़ी भी मिल जाएगी। कुछ लोग चाय वाय पी के आ रहे हैं तो ज़रा वेट कर रहे हैं, लेकिन स्टिल वेक अप। सो ये वेक अप कॉल फॉर यू गाइज एज वेल एंड वेक अप कॉल फॉर द फिजिशियन। दिस टॉक विल बी ए वेक अप कॉल फॉर ऑल ऑफ अस एज वेल। सो एंड लेकिन वेकअप्स के लिए एक दो क्वेश्चन करता हूं कि व्हाट आर द परसेंटेज ऑफ द पीपल इन योर प्रैक्टिस यूजिंग इंजेक्टेबल थेरेपी। इंजेक्टेबल थेरेपी कितने लोग हैं आपकी प्रैक्टिस में? कितने परसेंटेज है? 5%, 10%, 10 से 20%, 20 से 30%? कितने लोग हैं 5 से 10% वाले जो इंजेक्टेबल थेरेपी हैं? या 30% वाले कितने लोग हैं? ये देख लो, 2-3 लोग नजर आ रहे हैं। अच्छा, 20 से 30% वाले कितने लोग हैं? है ही नहीं। 10 से 20% वाले जो जिनके पेशेंट इंजेक्टेबल थेरेपी पे हैं, इंक्लूडिंग इंसुलिन, ऑफ कोर्स इंक्लूडिंग इंसुलिन इंजेक्टेबल थेरेपी। ओके, सो देयर आर सम पीपल। और अब सवाल है कि कितने लोग ऐसे हैं जिनका जो इंसुलिन पे हैं आपकी प्रैक्टिस में? 30% से ज्यादा कितने लोगों के हैं? मुझे मालूम है कुछ लोगों के होंगे। यस, 20 to 30%, 20 to 30%, जो कि एक फेयर नंबर है all around the world. And how many people have got an injectable GLP-1? कितने लोग ऐसे हैं जिनकी प्रैक्टिस में 1 से 5% आपके पेशेंट ऐसे हैं, या 5 से 10% ऐसे? 1 to 5. That is again a reasonable number according to the circumstances we are facing up, of course. So this is not a new slide, huh? Not a new algorithm. मेरे ख्याल में आप लोगों ने thousands टाइम देखा होगा, बाय हार्ट एक एक चीज इसकी याद होगी। और वो कहते हैं दुनिया में कोई नई बात नहीं, हाँ? दुनिया में कोई नई बात नहीं, बस अंदाज़े बयां बात बना देता है। और ये बात ही यही है कि कोई नई बात तो है नहीं यार, ये क्या आज कोई नई बात करने वाले हैं? बट वी ऑल नो दैट in this hierarchy of managing diabetes, GLP-1 are on the top of the list with the metformin and the SGLT2 inhibitors. So we know that the GLP has got the ample data, and and the GLP and top of the list, the semaglutide, which this program, the sustained clinical program, we know that the sustained clinical program has got a beneficial effect in terms of HbA1c reduction, in terms of body weight, in terms of cardiovascular and renal program. So we all know this. Semaglutide कोई नई दवा नहीं है, हमारे लिए भी आपके लिए भी कोई नई बात ऐसे नहीं है। तो आप लोगों को लग रहा है कि यार ये तो सारी पुरानी बातें हैं। So semaglutide has got this sustainable, and not only in people with in diabetes. And this is again the Sustain 6 program, which shows the exclusive people who has got a higher risk or having a cardiovascular disease. This Sustain program, the semaglutide, the efficacy, and that also shows a 26% risk reduction in the cardiovascular composite point, the cardiovascular problem. And then not only in the people with the diabetes, the semaglutide has got an impact, but in people who do not have diabetes, having an overweight or having obesity as well, this SELECT program has shown the tremendous results, about 20% composite cardiovascular risk reduction, again in those population who do not have diabetes, but they are overweight or obese. So, and of course, the body weight reduction in those population is up to 10 kg as well. So we know that the semaglutide in people with diabetes works, and in people who do not have diabetes but having the overweight or the obesity works together. But there is a big gap in the implementation of these guidelines. So how many of us, now we know that only 1 to 5% of the people in our practice using this GLP-1 agonist. Why not? क्यों नहीं ऐसा है कि जो हम प्रीच करते हैं वही प्रैक्टिस क्यों नहीं कर पाते? जो हम गाइडलाइन में देते हैं वही बात हम प्रैक्टिसेस में क्यों नहीं लेके आ पाते? There must be some reason about it. And this is one of the data from the US 2018 data. Only 5.4 adult patients with type 2 diabetes without cardiovascular disease and 4.1 with type 2 diabetes with established cardiovascular disease were prescribed GLP-1. And this is data where everything is available. हाँ, जो US कह रहे हैं ना, जिसको आप जहाँ पर सब कुछ मिल जाता है, वहाँ ये हाल है, तो पाकिस्तान में क्या हाल है? तो जो हम अभी देख रहे हैं शो ऑफ हैंड से, तो वो बिल्कुल सही अंदाजा है. And why it is so? And it is so. Why it is so? So the most common cause is the cost of the medicine. The cost of the medicine, and the next most common cause, the low rate of GLP-1 utilization, may also be in part because until recently, all GLP-1 agonists were administered by subcutaneous injection. So this is another reason. जो injection phobia है, वो एक और उसका reason है why GLP-1 are not prescribed as we are wished to prescribe this. हो सकता है हम लोग भी यही सोचते हैं, मरीज भी यही कहता है, नहीं इंजेक्शन, नहीं डॉक्टर साहब, इंसुलिन पे नहीं मानता, तो वो GLP-1 पे कॉस्ट के साथ कहाँ मांगेगा? So this was the real data. So now this is the paper again published in 2019. This is the new era for oral peptides. So आपको पता है इंसुलिन को आए हुए 100 साल से ज़्यादा हो गए. And even we don't yet have a oral tablet for the insulin. And why not this? क्यों नहीं बना पाए अभी तक इंसुलिन? This is not a easy job. So what to do? So क्या ये इतना आसान है कि oral semaglutide बनाना, tablet को बनाना, it's so simple? So this was a very difficult job, and just people think what to do, how to solve it, this problem. And ये ऐसी है जैसे एक अम्मा अपने बेटे के लिए ढूंढती है ना, चांद चेहरा और सितारा आंखें, हैं? लंबी जुल्फें हों, हरी आंखें हों, लंबे बाल हों, कद भी लंबा हो, ऐसा अपने बेटे के लिए ढूंढती है. अब माँ तो माँ ही होती है ना, बेटा चाहे जैसे भी हो तो ढूंढती है. सो वो आइडियल की तलाश में लगी रहती है कि कैसा आइडियल हो जो मेरी बेटी के लिए जो है वो रिश्ता तैयार कर. सो व्हाट आर द आइडियल पेप्टाइड्स? सो द आइडियल पेप्टाइड जिसके लिए आप which need to have, you can make a tablets or an oral medication, need to have a large therapeutic index, some stability in the GI tract, a long elimination half-life, and relatively low clearance rate. So ये सारी खूबियाँ उस शहजादी में होंगी तो वो घर की बहू बन सकती है. And luckily, semaglutide has got all of this. All of these, the semaglutide was considered an ideal peptide candidate for an oral delivery with a permeation enhancer on account of its low molecular weight, long half-life, and high potency. And this is the semaglutide in a snack, a co-formulation, and this snack is sodium caprylate. And an oral formulation of semaglutide was developed by co-formulation with formulating semaglutide and sodium caprylate, a well-characterized transcellular permeation enhancer to produce first orally administered GLP-1. So that was a very difficult task. By the way, liraglutide के लिए भी try किया गया था, लेकिन वो कामयाब नहीं हुआ. So what is the mechanism of action of this of absorption and protection? सवाल ये फिर आता है ना, क्या वाकई ये tablet absorb हो सकती है या नहीं हो सकती? So what is the mechanism of action? So after taking this tablet, the complete origin of the oral semaglutide tablet taking place in the stomach, not in the intestine. And the buffering action of this snack actually raises the local pH, and this neutralizes the acidic pH of the stomach, and this higher local pH helps to protect the semaglutide from the enzymatic degradation and promote monomerization, which is an important aspect in the absorption of this semaglutide molecule through intracellular, through the cells. And this snack fluidifies lipid membrane to increase the membrane permeability and allow the passage of semaglutide across the GI epithelia via the transcellular rate. So this is how it works. And then the next question, although it is absorbed, now can you may have a sustainable level in the blood level? Can you achieve it? So this is the data which shows that the pharmacokinetic analysis shows that the stable steady state concentration could be achieved with once daily dosing owing to the long half-life of the oral semaglutide. And more importantly, the upper GI disease and the renal and hepatic disease impairment did not have any effect on the pharmacokinetic profile. This is very important in day-to-day clinical practice. So what is the efficacy and safety of oral semaglutide monotherapy in type 2 diabetes? This is the Pioneer Trial 1. And just go briefly into that one. And this is the trial, the inclusion criteria, type 2 diabetes with an HbA1c of 7 to 9.5. And the 3 doses of the 3, 7, and 14 milligram were randomized into the 2 groups. And the main objective, the primary objective, was to compare the effect of 3 doses level of 3 milligram, 7, and 14 of once daily semaglutide with placebo on glycemic control and needed to when added to the diet and exercise in patients with type 2 diabetes. And the primary endpoint was the change in the HbA1c level from the baseline at week 26, and the confirmatory secondary endpoint was the change in body weight from the baseline to 26. So these are the baseline characteristics. You can see over here the HbA1c, the about 7 to 8, and the main age is about 55, and the body weight about 86 to 90. And these are the results. You can see how effective is the oral GLP-1 semaglutide, and you can see the difference in the HbA1c with the 3 dosage of the semaglutide, the 3 milligram for 7 and the 14, and the most HbA1c reduction you can see from the 14 milligram as well, and the about 1.5 percentage reduction with the 14 milligram and about 1.3 percentage reduction with the 7 milligram tablets. And this is the body change. Again, the dose-dependent body change, and about 4.1 kg weight reduction with the 14 milligram and about 2.5 kg reduction with the 7 milligram of oral semaglutide. And the patient which achieve less than 7%, more, about 80% of the patient achieve less than 70% of the HbA1c, and body weight of which greater than 5%, about 50% of the people with the 14 milligram dose achieve a level. And the patient which achieving the composite endpoint, this is the 73% is achieve the composite endpoint of this patient, and there is slight reduction in the blood pressure as well, about 5 mmHg reduction in the systolic blood pressure. And safety profile, you can see it has got the same side effect as the subcutaneous one, but they are more pronounced. The GI side effects are more pronounced with the oral tablet, and these are also dose dependent. The higher the the level, higher the milligram, this 14 milligram has got the highest one, but these side effects are initially are more as compared to the time which lapsed during the treatment. So in conclusion, the Pioneer 1 oral semaglutide was superior to the placebo in reducing HbA1c and body weight at the 14 milligram at 26 weeks in patients with type 2 diabetes. And the oral semaglutide helps more patients with type 2 diabetes achieving HbA1c target and the clinically meaningful weight loss compared with the placebo. And this is the efficacy when you compare with the other oral agent, and you can see the significant change in the HbA1c level when you compare with the other oral agent and the insulin as well. And this is the body weight change in when you compare with the other agent as well. So significant change in the HbA1c and the body weight with the oral GLP-1, the semaglutide, as compared to the placebo. And this is the propensity matching analysis using the data from the SUSTAIN and the Pioneer 1. And you can see about the 14 milligram matches with the 0.5 milligram subcutaneous dose. And agar 0.5 milligram subcutaneous dose or 14 ke result about the same. And this is the Pioneer. So I'm just go quickly to the Pioneer 5, which is an important aspect, the efficacy and safety of oral semaglutide in moderate renal failure. And you can see the reduction in the HbA1c and the weight loss as well, and the beneficial effect. And this is the Pioneer 6 with the cardiovascular, the people who has got the cardiovascular risk and having a cardiovascular event were randomized with the semaglutide in this one, and you can see the 21% reduction in the incidence of MACE and 53% reduction in the cardiovascular death in the Pioneer 6, which was an exclusive cardiovascular trial with the oral GLP-1. And this is the comparison of the SUSTAIN 6 and the Pioneer 6. That is the comparison of the subcutaneous semaglutide versus the oral glutide, and you can see there was about no difference. The HR ratio, the hazard ratio of 0.74% and 0.79% with the SEM. And this similarity of HR in Pioneer 6 and SUSTAIN 6 suggests that the cardiovascular effect of the semaglutide is independent of the administration route. इसका मतलब है कि दोनों का डेटा तकरीबन cardiovascular impact are the same. The last slide for this is the new one, the SOUL trial. I'm not going into the detail of this, but the SOUL trial was done especially in the high-risk individual with the cardiovascular who has got the cardiovascular event and the renal as well. So the result, you can see the 14% reduction in the primary, the card MACE, 26% reduction in the non-fatal MI, and the 12% reduction in the non-fatal stroke, and there is a benefit in the major adverse limb as well in this fellow. So in conclusion, the oral semaglutide was superior to the placebo in reducing the incidence of 3-point MACE in people with type 2 diabetes with atherosclerotic disease and CKD, and there was consistent CV efficacy of oral semaglutide across all subgroup by sex, age, and BMI. The overall safety profile of semaglutide in SOUL was similar to that observed in the previous clinical trial. So in summary, my dear friends, the development of oral GLP-1 represent a significant milestone in the management of type 2 diabetes, providing an additional efficacious treatment for our patient. Thank you very much for your patient listening.
Before I ask the audience to take some question, I would request Professor Shabnam Koriju to take her seat. Come here. The individual behind the show. Now, we have a time for 2 or 3 brief questions. If any in the audience would like to ask the question to the presenter, he can do so. Yes.
Point, point 0.5 milligram is about equal to 14 milligram of semaglutide, 0.7 according to the weight. There are trial are going on with the Sol Plus trial is going on with the 25 and the 50 milligram of semaglutide, which is in pipeline, and the results are in waiting. We are waiting for that results.
अस्सलाम वालेकुम सर।
Please.
सर ये सीमाग्लूटाइड जो टेबलेट है, क्या इसके डायबिटिक की दूसरी टेबलेट इसके साथ दे सकते हैं?
इस सवाल के दो हिस्से हैं कि क्या एक साथ दे सकते हैं
हाँ हाँ,
या कंबाइन कर सकते हैं।
कंबाइन करके।
तो दो हिस्से हैं इस सवाल के। तो एक तो ये कि आप जब भी सेमाग्लूटाइड दें तो अलोन दें, किसी दवा के बगैर दें, यानी कि सुबह ही सुबह दें, बगैर नाश्ते के दें, एक गिलास पानी के साथ दें, और उसके आधे घंटे बाद वो कुछ ना लें।
सर इसके
एक हिस्सा। दूसरा हिस्सा सवाल का यह है कि कैन वी कंबाइन semaglutide with the other oral agents? Yes, of course, the Pioneer 1, 6, 7, 8, 9, 10, 11 programs are now there. So yes, you can combine with the other, except किसके साथ नहीं देंगे? जाहिर है DP4 के साथ नहीं देंगे।
ठीक है सर, थैंक्स।
14 मिलीग्राम जी, this is daily dose, yes.
The only obese patient, या only diabetic with obese patient?
ओह, सेलेक्ट ट्रायल ने ये साबित कर दिया, जो मैंने ट्रायल दिखाया था, कि नॉन ओबीस और नॉन डायबिटिक एंड ओवरवेट एंड ओबीस सीमाग्लूटाइड, उसका बहुत ज़बरदस्त रिजल्ट है उसमें। जैसे कि 20% रिडक्शन है द कार्डियोवैस्कुलर एंड द वेट रिडक्शन ऑफ अबाउट 10 kg. So you can use the oral, the extrapolating the data. We don't have the oral data, तो वो आप एक्सट्रापोलेट कर सकते हैं। यस, ऑफ कोर्स नॉन ओबीस में भी कर सकते हैं।
Thank you very much. Now, I would kindly request our panelist to conclude it. Dr. Asma. Aisha.
Very nice presentation by Dr. Zahid, and he has cleared all the points regarding the use of oral semaglutide. And being a nephrologist, I want to add that most of the patients that come to the CKD clinic and that come to the nephrology OPD have multiple comorbids. They have diabetes and hypertension and ischemic heart disease. And diabetes is the leading cause of chronic kidney disease in Pakistan. So most of the patients that are coming to the chronic kidney disease clinic or nephrofilter OPD have diabetes. And as the GFR decreases, we have very few options left to treat the patient. The oral semaglutide and the injectable semaglutide both have proven safety in chronic kidney disease patient, and they decrease the urine albumin creatinine ratio, preserve GFR, and it is very safe to use in chronic kidney disease patient. Dr. Zahid is right that to counsel a patient to use an injectable medicine is very difficult, and the chronic kidney disease patient, they are already taking erythropoietin, they are already taking injectable erythropoietin, injectable iron. So it was very difficult to counsel them to start another injectable medicine. So an oral medicine and oral GLP-1 agonist is very beneficial, and it's very easy to start in chronic kidney disease patient. And as shown in the Pioneer 5 studies, is decreases the urine albumin creatinine ratio. That is the main thing, that if the urine albumin creatinine ratios decrease in diabetic patient, it preserves GFR. So we hope that use of this medicine, oral semaglutide in chronic kidney disease patient, will preserve the GFR and decrease urine albumin creatinine ratio in diabetic patients.
Sir.
As usual, Dr. Zahid has presented very well, I would say. But I think most of our physicians, when they start anti-diabetic drugs, they just have the target of just reducing blood sugar. They don't consider cardiovascular outcome. But whatever the panel is, when agonist drugs was basically used, started for diabetes. And they have different trials that have been shown for reduction of weight in different doses of drugs. Regarding the mechanism of cardiovascular decrease in cardiovascular events, so we don't know the actual mechanism of it, but it is said, it is presumed that semaglutide has this anti-inflammatory effect that causes a reduction in cardiovascular events. So most of the patients who come with us, they are mostly obese. Cardiac patients, they are obese. So we have less option for liposuction and sending the patient for surgery. I think semaglutide in an oral formation, those patients who are hesitant of having injections of semaglutide per week, oral semaglutide is a good entry for such patients. Thank you.
Okay, thank you very much, sir. Uh, the recently concluded International Diabetes Federation conference, where the president of IDF, president of ESD, and president of ADA, they have got a consensus statement that you should individualize the patient's care and give the best drug and cost effective. And cost effectivity is the main factor of enhancing the diabetes among all ages, especially type 2 all over the world and especially in Pakistan. Remember, the obesity and diabetes has got a highest risk in Pakistan, that is 24%. A diabetic with obesity has got 24% risk of malignancy. Okay. So, semaglutide, we have learned about it. Semaglutide is about a decade in the practice, and now the oral form. And as Dr. Zahid has very categorically said, that the pioneer series of studies is starting from giving it alone with placebo, giving it with metformin, giving with other medication, and as Aisha rightly said, they have also tried it in people of moderate renal impairment, EGFR between 30 to 50. And I'm sure with the passage of time, it will come even down. So that is the one thing which is, I think it's a good news, and we are not going to jump into the conclusion, but that is certainly a card to play in poor and needy people. And GLP-1, there is no doubt about its efficacy as far as diabetes and as far as weight reduction of its effect is concerned. And all the things which I say and conclude with all the panelists, this is the one thing which will help reduce the weight and reduce diabetes, and that is the weight reduction with diabetes reduction is a mental satisfaction of the patient. And if the patient is not mentally satisfied, he is going in a disturbance, okay, and that lead to enhancement of many factors. This is the one other important factor which we discuss. Okay, if the sleep is disturbed due to anxiety, that is going to compound it. Now, semaglutide orally and IV has been tested extensively, so we have no doubt about its efficacy, because there are many drugs which have been in the past used for weight reduction, and there was one drug which about 2 decades ago came came in the market with that, the wonderful drug. And when the people asked that what happened to that patient, and they said कि मरहूम जब मरे तो बहुत दुबले से, because fenfluramine was the one drug which resulted in valvulopathy and eventually taken off the market. So it's a good addition as far as the treatment is concerned. It's cost effective, and I think it will be the one thing which is a card in the pocket of poor and needy. Thank you very much.